Thank you. Good evening, everyone. A very warm welcome to our Tuesday Masterclass from the Department of Critical Care Medicine, Yashoda Hospitals. So I'm Dr. Kaladhar, today's moderator for our Masterclass. So we are having this program since almost 4 years. Just I was looking back when it was started on 1st February, near to completion. I think we have Dr. Venkatraman Kola sir with us as the mastermind behind this and the driving force. So today's topic is preeclampsia and eclampsia. As everybody know, this is the intersection between obstetrics and critical care, where it poses like an emergency. So where there will be very high hypertension, pulmonary edema, acute kidney injury, seizures, landing up in eclampsia, HELLP syndrome. So many complications can happen because of this disorder. As we see more and more elderly pregnancies are happening nowadays, this poses a major risk. And we do get a lot of patients like this in our ICUs day in and day out. And definitely managing this patient becomes a very important part among multidisciplinary coordination and collaboration, because involving the critical care physician along with obstetrician, anesthesiologist, emergency physician. So everybody has to involve. So it becomes very paramount important in this managing these cases. So I welcome you for this session. For today's session, we have expert panelists with us. Dr. Sharmili Sinha ma'am. She is the Senior Consultant Critical Care Medicine, Apollo Hospitals, Bhubaneswar. We know about her. She worked as a Vice President ISCCM in the previous session. So I welcome you, ma'am, on board.
Thank you. Thank you, Dr. Kaladhar, Dr. Venkat, and Team Yashoda for this excellent initiative. Happy to be here.
And I welcome Dr. Amarja Avaldar, ma'am. She is a professor of critical care medicine, St. John's Medical College. So much known, very proactive in academics and research. I collaborated with her in one of the research topic. Welcome you, ma'am, Amarja, ma'am.
Thank you. Thank you for the invitation. Thank you.
So I welcome Dr. Sachin, is the DRNB Critical Care Medicine resident, and Dr. Jeevan Reddy, IDCCM resident at our hospital, Yashoda Hospitals, Malakpet. They both will be presenting the case scenario that we dealt with in our ICU. And both of you can go forward presenting your topic, Dr. Jeevan and Dr. Sachin.
Good evening all. Myself, Dr. Sachin.
Good evening all. Myself, Dr. Jeevan Reddy.
Today's topic is preeclampsia eclampsia. My patient is a 31-year-old female patient, resident of Nalgonda. She is a housewife, primi gravida, 33 weeks. Presented to ER with chief complaints of history of seizure, 2 episodes, 1 day back, and altered sensorium. History of presenting illness. Patient was apparently normal 4 days back when she developed headache diffuse in type. Lasted for 5 hours associated with nausea, blurring of vision, followed by 1 episode of vomiting. Consulted local hospital for the above complaint and was told to have higher BP recordings. And she was started on labetalol 100 mg BD and injection dexamethasone 6 mg IM BD for 2 days. They have given. Later, after 2 days, had complaints of headache. Patient was reviewed and recorded to have high BP and was taken up for emergency LSES at around 6 p.m. On the next day at around 1:30 a.m., patient developed tonic-clonic activities of all 4 limbs, uprolling of eyes, deviation of head towards the left, frothy discharge from mouth, with confusion lasted for 30 minutes. And she received injection magnesium sulfate and were referred here in view of for further management of seizures. Past history. No known history of diabetes, hypertension, seizure disorder, hypothyroidism, neuromuscular disorder. And she is on regular antenatal visits. And her personal history is mixed type, appetite adequate, bowel and bladder was regular, sleep disturbed since 5 days.
So I just want to interrupt here. During ANC checkup, you told about BP recording. So how you can confirm that patient is fitting into criteria of preeclampsia? Or is it some other entity which can tell you, is it chronic hypertension or gestational? So can you just explain what are these terms and how
Yes,
we
ma'am.
can confirm?
So preeclampsia is generally described as BP recordings of more than 140 of systolic blood pressure and more than 90 of diastolic, more than 90 mmHg of diastolic blood pressures after 20 weeks of gestational period, madam. So with associated with the proteinuria and other organ damage features, madam. So in case of a chronic hypertension, it is described as if patient is having blood pressure recordings of more than 140/90 in pre-pregnancy period or during the pregnancy before 20 weeks of the pregnancy or postpartum after up to 12 weeks of pregnancy, madam. And gestational hypertension is described as BP recordings of more than 140/90 mm of Hg yet after 20 weeks of pregnancy without any proteinuria and other features, madam.
So why this cutoff of 20 weeks? Why it is not any other weeks? Why 20 weeks is specific for diagnosis?
So this is syncytial spiral artery, trophoblastic invasion of the spiral arteries and the associated features will be happening only not in the early phase of the pregnancy. The pathophysiology behind this is trophoblast spiral artery invasion is impaired and that is leading to that angiogenic changes and increased VEGF factors and leading to vasoconstriction, and those changes will be taking some time, madam. So they are taking as a 20 weeks of cutoff rather than early phase, madam.
And what are the changes in hormones with respect to 20 weeks? What happens in normal pregnancy? What happens during 20 weeks?
So the progesterone levels will be because of the in the pregnancy progesterone levels will be higher and there will be systemic vascular resistance decreased, madam. So yet that from these levels onwards the progesterone levels also will be decreased and there will be rise of the blood pressures, madam.
So mid-pregnancy, 20 weeks, usually you see there is a drop in blood pressure. So that is normal. And after 20 weeks, if you are seeing there is a high blood pressure, like more than 140 or more than 90 diastolic, and it should be seen, means 20 minutes apart and two readings. That is a definition. That fits into the definition for gestational hypertension. And do you think there is a need for having proteinuria to tell it is a preeclampsia?
With or without proteinuria, madam. So definitely it need not be a proteinuria present, madam. So with or without proteinuria, with other features of raised creatinine of more than 1.1 or double the baseline, or pulmonary edema, epigastric pain, thrombocytopenia of less than 1 lakh per microliter. So those features also can be taken into consideration, madam. So
Okay.
What Dr. Jeevan and Dr. Sachin, what is the importance of proteinuria in ANC practice in a country like ours? What is its implication of checking for proteinuria during ANC visits?
So the proteinuria can be one thing, madam. In setups like us, there could be some CKD background in the diabetes because the diabetic epidemic. So there may be some diabetes induced chronic kidney changes, or there could be some increased NSAID use at the peripheral level. There could be some kidney injuries. So and some tropical fevers also can be showing changes in the proteinuria, and sometimes there could be because of the proteinuria there would be pedal edema and all patient will be landing up in some other complications. So you need to look into the proteinuria.
So if you actually discuss with us obstetricians guidelines and the practitioners, proteinuria is actually and one of the early signs before blood pressure recordings, higher blood pressure recordings are found. We know the number wise 140, 90, we talk about it. But suppose your blood pressure is say 125 or 130 and still your urine dipstick is 2+ or more, then also it is an ominous sign and it's a very strong indicator of development of preeclampsia. You
Yes,
can
ma'am.
very well start putting these patients on low dose of antihypertensive from that point itself. So proteinuria is an important thing, and that's why, because it is a very doable thing, point of care test sort of. So dip test is actually advised at most of this ANC visits as a screening test for patients, especially who have all these risk factors. Even now, if the obstetricians also advise for patients more than 25 in the early, I mean, who are not so old by age also, to go for urine dipstick test, so that you can emphasize on the blood pressure measurement more frequently than before. And regarding this 140/90, the numbers are there. But remember, if it is even less than that, but proteinuria is present, consider these patients as kind of preeclampsia only. They have to be frequently visited. You can advise for early confinement, etc., and more care, or early referral to a higher center for follow-ups.
Yes, ma'am.
So
Yes, ma'am.
when you said about this, actually, I would let you present the case, then we can go on to ask the questions. So after past history, is that okay, Dr. Amarja?
That's fine. That's
Yeah.
fine.
Yeah. Proceed. Yeah.
Marital history, married life for 8 years, non-consanguineous marriage, conceived under IVF treatment, and family history of nil significance. On arrival to ER, airways was patent. Breathing saturation was 91% on room air and 99% on 2 liters of O2 with nasal prongs, and with a respiratory rate of 20 per minute, and right basal crepitations was present. Circulation, BP was 150/90 and heart rate was 110 per minute. Regular, warm peripheries, S1, S2 heard, and no murmurs. Disabilities, patient was drowsy but arousable. GCS was E3, V4, M6. Bilateral pupils 2 mm. And deep tendon-test reflex is 3+. And GRBS 113, moving all 4 limbs, no focal neurological deficits, and exposure temperature is 98°F, and per abdomen findings are soft tenderness present over the incision site, no organomegaly. And left hand IV cannula of 20 gauge in situ with IVF with NS on flow, continuing with magnesium sulfate of 4 gram. And ABG is pH is 7.5 and PCO2 of 25 and PO2 61 and bicarb of 22.7 and lactate 1.6.
Because you're presenting the ABG, would you like to interpret the ABG?
Respiratory alkalosis with type 1 respiratory failure.
So this is on room air.
Yes, ma'am.
Yes.
Okay. And what about other values do you have? Sodium, potassium?
Yes, ma'am. Next value is ma'am.
Okay.
General examination, moderately built, moderately nourished, no pallor, icterus, clubbing or cyanosis, bilateral pitting pedal edema present. And provisional diagnosis is pregnancy-induced hypertension with eclampsia, plus CSVT and HELLP syndrome.
You mean the differential diagnosis?
Yes,
Yes.
yes, yes.
Differential diagnosis.
So there was no history of fever.
No,
No
ma'am.
history of fever.
Okay.
The
Right.
investigations wise, CBP hemoglobin of 12.9, PCV of 38, total leukocyte count of 16,400 and platelet of 1.35 lakhs. LFT total bilirubin is 1.1 and SGBT of 45 and SGOT of 57 and GGT 41 and ALP of 110 and protein 5 and albumin 2.6. RFT creatinine is 0.8 and blood urea nitrogen is 10 and the blood urea is 23. Sodium of 134 and potassium of 3.8 and chloride of 102. RBS was 83 mg per deciliter and CUE pus cells occasional and RBC nil glucose negative, but protein was 3 plus, and ketones negative.
Okay.
So the PT-INR was PT of 15.2 with INR of 1.1, madam. Serum uric acid levels of 9.6 with serum calcium of 8.6 and serum magnesium of 3.8 milliequivalents per liter. And there is a raised D-dimer value 2317. So, and the chest X-ray was showing right lower zone infiltrates, and the ECG was showing sinus tachycardia with 2D echo, no regional wall motion abnormalities, good LV function, no RARV dilatation, and IVC collapsing, madam.
Okay. So at this point, at this, let's stop here. I think there is a lot of information clinically and investigation-wise we have obtained now. So what are the points of concern at this point with this lady who has been shifted with GCS, I understand 13. She had LSCS, seizure. Now she has been shifted to you from a peripheral center. What are the points of concern here?
Airway.
So because the patient is post-seizure, madam, so and there is some decreased sensorium, so there is any risk of further worsening of the seizures. There is a possibility of some status epilepticus. So in that situation, we have to secure an airway, madam. So in pregnancy, during pregnancy, because of the estrogen levels, there is an capillary engorgement and there will be airway edema. So I need to have secured this lower numbered ET tubes, madam, so that in order to secure the airway in a proper way, madam. So, and also as the patient has lower saturations, hypoxia. So, if any further worsening, I need to take care of this, madam. And as this patient has in seizures, either it is chemical pneumonitis or some aspiration pneumonia. So, it may lead to further sepsis component and any shock may also develop. So I need to secure the wide bore cannulas at the earliest so that the anticipated shock can also be addressed with fluid resuscitation and then later on vasopressor support, madam.
So regarding the point 1, threatened airway, do you think she needs any immediate airway protection?
No, madam. As such,
at this point, probably not.
No, madam.
No. And number 2 is about the shock. The blood pressure was actually, in fact, on the higher side, no? 150 by 90, you said.
Yes, ma'am.
So it's a good idea to have good IV lines, but imminent development of shock, I mean, probably not there immediately. Yeah. So next.
And because here there is a situation of hypertension, I need to address the hypertension so that further worsening of the hypertension may not be happening, and that may not lead to further seizures or cerebral autoregulation and leading to blood-brain barrier disruption and other features, madam. So I need to control the blood pressures at this point. So that also should be my first and foremost priority.
What will be your target for blood pressure?
So here it should be around 140 by less than 140 by 90, madam. But it should not be rapid correction. So at least over 15%, 15 to 20% reduction over 4 to 6 hours. Slowly we need to control, madam. Rapid reduction also can lead to further worsening of the scenario.
Okay, and next.
So, and also because the patient had there is some low platelet count, madam.
Platelet count was normal, na? 1.35.
1.35. So, and also there is a significant proteinuria in this urine, madam. So all these point towards preeclampsia to with the seizures, that is an eclampsia. So my already as the delivery has happened. So and the second thing is as the delivery has happened, any further seizures occurs. So the incision site may lead to any rupture or any. So I need to take care of the surgical site also, madam, in this patient.
What about the saturations and the oxygen level?
Oxygen levels at room air.
He came on room air. Did she come with some oxygen from the other place?
Yes, ma'am. We have kept 2 liters here, madam. In our year, we have started on.
No, but when she was shifted from the other hospital, was she given some oxygen during transport?
No, madam. They were shifted in the room air only, madam.
On the room air only.
Yes, they have shifted in the room air. So here we got on 2 liters of O2, madam.
And she was on magnesium infusions.
Yes, ma'am.
Yeah. So these are the points we need. Yeah, tell me.
And as there is a magnesium infusion, so I need to take care of the magnesium levels and dependent reflexes, so respiratory rates and urine output should be closely monitored. So all those things also has to be seen, madam. And also ECG, any PR interval changes also has to be seen, madam.
She has a sinus tachycardia, you said,
Yes, ma'am.
110 heart rate.
Yes, ma'am.
So what are the points actually of concern in transport of these patients? Because in a country like ours, many patients like this patient delivered in a smaller setup and then was shifted to you after a complication of seizure. She was not tubed. I mean, probably it was not required, but she was not even given oxygen during
Yes, ma'am.
transport. And the IV cannula, I noted what there was a 20 gauge cannula in one hand only. So
Yes,
for a patient who had a serious complication of a seizure postpartum with this high blood pressure, being shifted with only one cannula. So what are the points that is suppose I think your many bigger hospitals are now covering many smaller places with tele-ICU facilities. What would be your advice to that previous or the referring hospital for safe transport of such patients? Because these are the things which actually make an impact on the subsequent course and recovery of the patients. These patients just might seize, an aspirate, and by the time they reach you, things will be different. And number three is most catastrophic is about the magnesium infusion. How it is given, because magnesium toxicity can happen if it's not properly labeled, if it's
Yes,
not
ma'am.
an infusion, the information is not accompanied by a trained personnel. It can just run and patient will have bradyasystole and death. So these are the few points I think we need to emphasize about the intra-hospital or inter-hospital transport of this critically ill pregnant woman also.
Yes.
So what are your points? And if you have to advise to a peripheral center before they shifting such a patient, what would you tell them?
So the
And-
same things of ABC has to be addressed, madam. So I would like to first emphasize upon for them. So airway. So for that, any technician or any doctor if available, yes, that is well and good. But if not possible, any technician to take care of the airway should be, or an ambulance which is well equipped with the services should be the first priority, so that patient in between in the transit there may be untoward incident may not be happen, so that the uh, unwanted maternal mortality would be prevented, madam. So, and second thing, so because as there is a possibility of aspiration, so the positioning of the patient during the transport, left lateral position, and also trying to have minimal O2 support, I mean, if at all, if required, so that is nearby. And the third thing, so as there is patient has been on magnesium sulfate infusion, so ideally, it should be some Foley's catheterization should be done, and at least in the transit, at least 2 to 3 hours. So at least for every hour, urine output, how it was there, whether it is decreasing, then and there itself, the technician can stop the magnesium sulfate infusion during the transit itself, so that we can avoid certain magnesium complications during the transit. So, and having a monitored, I mean, ECG leads and connected to the monitor, so that any bradycardia changes can be early picked up even by the attender who is accompanying the patient during the transit. So that patient attender education also can help better in this scenario, madam. So I would like to say these
Yeah, and
points.
at least two lines.
And
These
as you
two
said,
lanes. 20 gauge for an adult patient is a very small line, and that too with that kind of complication, hemodynamic and respiratory complication in the pending. Two good lines are necessary. So once she has now received, you have received this patient, I think you have done the needful. And then what? How do you like to evaluate her now?
okay. So, because the patient has presented with a new onset of high blood pressures with seizures, so in the postpartum and peripartum period, so this could be either most probably the preeclampsia or eclampsia. So, for that to evaluate, so the classification to classify, so my platelet counts and my liver enzymes and LDH, lactate dehydrogenase values can be helpful to categorize the things, madam. And at the same time, all seizures may not be because of the eclampsia and preeclampsia. So there could be other possibilities of the seizures, like from the metabolic causes like hypoglycemia or hyperglycemia, hypocalcemia or hypercalcemia, hyponatremia or hypernatremia. So my electrolyte panels, so I have sent my electrolyte panels, so sodium, potassium, and all have been looked into, madam. And at the same time, there could be some changes in the brain, so that could be an acute ischemic stroke and also present as a and she has a hypertension. There could be possibility of the hemorrhagic stroke. So to rule out all those possibilities, I need a neuroimaging, madam. So we have done MRI done, madam. So
What would be your
neuroimaging.
neuroimaging of choice at this point?
So
CT.
already as the delivery has happened, so I can safely immediately lesser time, so I can go for non-contrast computer tomography of brain would be my choice.
Yeah,
Madam.
was that done for this lady?
We have the facility for the things and to take care of the airway, so we have gone for MRI brain in this case, ma'am. So that
that
other
is good. You are a tertiary center, you could do the MRI.
yes,
But
ma'am.
at any given point of time, even for a tertiary center, suppose this patient has come to emergency after initial stabilization and addressing the concerns that we discussed, what do you think would be quicker? Because MRI would take
At least
for
30.
30 to 40 minutes transport in and out of the channel, I mean, of the tunnel and all that. So will a quick CT would be a quicker one if you have an option between a CT and MRI? Of course, MRI gives you more detailed information, there is no doubt. But in terms of logistically and patient safety point of view, in the first few 6 hours in the emergency, and you're trying to wheel this patient to the ICU for further management, I think a simple non-contrast CT will also suffice to, because as you rightly said, you also have to rule out more important and more sinister causes like intracranial bleed or infarct. Once that you have excluded, of course, with the history is very, very strongly suggestive of a preeclampsia with now developing eclampsia, and she is in just post-ictal state. And anything else we would see, all electrolytes, sugar, etc., have been. You have already seen these cases, and I think the TLC. Have you mentioned about the blood picture? Yes,
Yes, ma'am.
the TLC is 16,400. What do you think about this leukocytosis?
So there could be increased leukocytosis in the pregnancy itself, madam. Pregnancy induced mild leukocytosis is possible. And another thing is there could be stress induced. Or third thing could be in the immediate post-operative period, there is minimal rise of TLC, madam. So our peripheral smear hadn't shown any left shift or immature cells. So we think it is more of reactive, madam. So for the time being, we think of
Do you think this patient could be having ongoing non-convulsive seizures? See, obviously, she is not seizing, but is there a possibility she is drowsy 13 GCS? Is there a possibility of having ongoing non-convulsive seizure from the presentation and from all the values that you saw in the ear?
But the ongoing non-convulsive seizures, so we feel it could be less likely, madam, in this scenario.
Why?
That complete sensorium drowsy arousable, but not now the confusion has been overcome, madam. So there is the initial confusion for only half an hour. So now there is no continuous.
She was fully conscious after that, after half an hour.
Yes, ma'am.
Okay.
So possibility of that I feel less likely, madam, but I may be wrong.
Yeah, because the sorry, the ABG, if you see, that is rather actually an alkalosis, more of a respiratory alkalosis. There is acidosis is not there, even the lactate is in the normal range. So
1.6.
the fact that she probably did not have a prolonged tonic-clonic seizures,
Yes, ma'am.
not even low grade lactate has been normal. Yeah, somebody wrote that rightly. So these are the things which actually tells you that probably she's not having an ongoing seizure activity. What is the implication of that? Why you need to think about it? Because she has been receiving magnesium infusion. You have got the level also. I think acceptable DTR is fine, urine output is there. Why we need to know that immediately? If you have a provision of EEG, probably you can do it.
Yes, ma'am.
If there's a visible seizure, you know. But if not, then why you need to make sure that there is no non-convulsive seizure going on?
So if at all any non-convulsive status is going on, so it is going to have a long-term neurological impact over the patient, and
Exactly.
indirectly it will have the impact on the newly born kid also, baby. So we need to take care of the
Baby has been delivered. So that has been.
yes, ma'am.
Yeah.
But mother, if no mother, then child will have that emotional bond and family will be going to distress. So we need to address the mother in a most appropriate way. So that is the reason why we need to look into that any non-convulsive status or any status epilepticus ongoing. So in that scenario, we may even have to readjust our regimen, and we may need to even go for other anticonvulsants also if needed, madam, like lorazepam and all. Midazolam.
Yes, because it's not only magnesium. If a patient has got ongoing seizure, either visible or non-convulsive, then other antihypertensive, anti-epileptic agents, like as you said, either the benzodiazepine groups or levetiracetam, which is most commonly being used, maybe has been delivered, should be used in these patients, because the neuronal cells once get damaged, you have reversible high chances of hypoxic ischemic encephalopathy and limited neuro recovery chances are there. And yeah, so what next? Dr. Amarji, you want to ask anything? Actually, I cannot see you in the screen. My screen is limited for somehow my view.
One question regarding liver enzymes. So, can you interpret, is it in normal range or is it elevated with respect to pregnancy cutoffs?
So they were slightly elevated, madam. So more than 40. So in severe health like health syndromes, there would be more than 70, madam. But here it is more than 40. So SGPT and SGPT both are more than 40, madam. So there is slightly elevation of the thing, madam.
So cutoff is around 35 to 40.
Yes,
So
ma'am.
if we see the value of 70, we may think slight elevation, but with respect to pregnancy, it's a doubling from the normal. So it is
Yes,
one
ma'am.
of the criteria for HELP. So we need to be aware that what are the cutoffs with respect to pregnancy.
Yes.
All right. And next,
And
what
one,
is the role of POCUS
yeah.
here? Yeah.
One
You
more
want to
thing
ask
is, what is the reason to do CT scan or imaging? What was whether it was really indicated in this patient?
Madam, even though it is more looking like an eclampsia, but there are other possibilities like central sinus venous thrombosis also possible, and there could be some Press syndrome, posterior reversible encephalopathy syndrome. Other differentiations are there. So in such scenarios, so going for an imaging so that early, if you are identifying, that would be more beneficial. Later on, after going and patient is not recovering, then looking at the things would be uh, time lapse, madam. So early imaging would be helpful because the patient is also giving us time to have an imaging at this point, madam.
So this patient is post-delivery. So in spite of that, the seizures are persistent. And you can't tell that it is related to eclampsia alone.
Yes,
Hence, you have to consider for other differentials. So in case of eclampsia, how long seizures can persist?
So
60 to 90.
up to 6 weeks of the postpartum also there is a eclampsia seizures will be there, madam.
Yeah, so that doesn't mean that is the only diagnosis. We have to rule out other possibilities also.
So, Dr. Sachin and Dr. Jeevan, what was the role of POCUS here? I mean, you did a 2D echo to look at the cardiac function. Was it necessary? Or what was the indication for doing an echo in this case at that juncture?
So as we have thought, one differential of cerebral sinus venous thrombosis. So any thrombotic tendency, so pulmonary thromboembolism features, RA-RV dilatation can be picked out with our POCUS also, madam. I mean 2D echo, and also with POCUS we can look for any thrombosis in the limbs, lower limb thrombosis also we can, deep vein thrombosis also can be seen through our POCUS. And also the POCUS sometimes helps, I mean, with a qualified expert hands. So the POCUS can help in looking at the optic nerve sheath diameter and our transcranial Doppler also, so that any raised intracranial pressures also can be seen, identified at the bedside with the simple versatile tool of POCUS, madam.
I'm talking about the cardiac echo. Do you think is there a possibility of embolism here, pulmonary embolism, if at all? Deep vein thrombosis or pulmonary embolism?
As such, we don't, we not having that, but there is some hypoxia with respiratory alkalosis. So that could be another differential for pulmonary thromboembolism. I mean, in pulmonary thrombolism also there could be possibility of hypoxia with respiratory alkalosis, and being pregnancy is a hypercoagulable state. There is possibility of that also, madam. So seeing at that with 1 to 2 minutes, it is helpful.
So actually, it has almost, as we discuss in many conferences, it is replacing stethoscope. So you're into the habit of doing an echo, but it's nonetheless, it's good. There is nothing right and wrong.
Yes,
I
ma'am.
just want to understand why you do it. But I think it's not a bad idea to look at the cardiac function at this point, because from the history, it is very evident that she has a severe preeclampsia going on to eclampsia. she has serious complications. And many of these cases, remember, also might have some degree of peripartum cardiomyopathy.
Yes,
So it's actually not a bad idea to have a quick look at the systolic ventricles. And if any kind of, the extremes of IVC diameters also can hint you at because many of these patients are also fluid depleted, though blood pressure is on the higher side. As you said, 150/90, they may be fluid depleted. And that could be a prerenal component to AKI if at all she had. So it's not a bad idea, but you have to justify why you want to do it, but not everybody. But I would advise you not to talk about looking for the DVT at this point. I mean, the
Okay.
long legs and all that, it's going to take time. Quick look
Okay.
at the chest and the IVC is fine.
Yes.
And yeah, next I would just go to so you did an MRI. Let's complete your score, the patient story. Yeah.
So MRI brain with a MRV showing multifocal cortical edema with flare hyperintensity is noted involving bilateral frontoparieto-temporal occipital lobes, including bilateral capsuloganglionic region and splenium of corpus callosum. Likely posterior reversible encephalopathy syndrome, small calcified granuloma in the left temporal lobe. And neurology opinion taken for this and advised levetiracetam 1 gram IV twice daily.
Yeah. Next.
Day 1 of post-op day 1 in ICU, patient was drowsy, arousable of GCS of E3, V4, M6. Bilateral pupils were normal size, reacting to light, and temperature of 98°F, and pulse rate of 110 per minute, regular rhythm, and BP 160/90 mmHg, and GRBS of 96 milligram per deciliter, and SpO2 of 91% on room air and 99% on 2 liter of oxygen nasal prong. Respiratory rate of 24 minutes, and CNS of deep tendon reflex of present, and right radial arterial line inserted and Foley inserted.
Which
What is
deep
the
tendon reflexes do you check for in these cases?
Especially patellar reflexes.
Patellar reflex for
The knee reflex, knee joint.
Major.
Yeah.
What is the indication for arterial line?
So because the blood pressures were on higher side, and we need to closely monitor the blood pressures between 140 to 160. So rapid correction should not be happening, and the rapid rise should not happen. So in order to have a proper control of the blood pressure readings, so it is we have secured for the arterial line, madam. And any further seizure episodes also happening, so the non-invasive blood pressure monitoring would become difficult to interpret the things also, madam. So we got to secure the arterial.
And she was started on magnesium sulfate 1 gram per hour, madam, and injection levetiracetam 1 gram IV 12th hourly, and injection paracetamol, pantoprazole 40 mg IV once daily, injection labetalol 5 mg IV stat given, and tab nifedipine of 20 mg per oral 8th hourly started, and injection paracetamol 1 gram 8th hourly.
Why nifedipine is chosen as a drug of choice for controlling blood pressure? Why not other drugs?
Because the recent meta-analysis of various network meta-analysis of randomized trials have shown the relative better evidence of nifedipine role compared to the labetalol and hydrogen, madam. And nifedipine is and oral supplementation we can give, and labetalol, there is a possibility of bradycardia also can happen. So in this scenario, and with lateral bradycardia with the hydrogen reflex flushing and other things, so better nifedipine, as the evidence is more towards nifedipine, we have gone for nifedipine.
Is there risk of precipitous fall in blood pressure with nifedipine?
Yes, with nifedipine, there is a rebound hypertension would be there, madam.
So this patient is post-delivery.
Yes,
You
madam.
have to look at which are the drugs which are harmful, because if there is a breastfeeding and lactation, that part you have to look into while choosing the drugs,
Oh,
isn't it?
yes, ma'am.
And any particular contraindication for any drugs during pregnancy, if you have to answer? Which drugs are contraindicated? Antihypertensives.
AC inhibitors, madam. So, like our captopril, lanzapil,
Okay.
and
teratogenicity.
relapsing stenosis.
Because here I can see you have started with injectable labetalol. Why not continue as an infusion and control the BP adequately? You have placed art line as well.
Yes, ma'am.
Why to switch to oral?
So,
That is the question.
yes, ma'am. As you have rightly asked, so with the thing is, so initially the BP recordings were not bit 150/90, and they are getting under control with the levetolol. And we thought so early oral can be making the patient to early shift out from the ICU, and early mother-child bonding also can happen. Patient also will have lesser burden of financial burden also with a lesser ICU stay. So we opted for oral medication, madam. Anyhow, we have IV arterial line. If needed, we can go with the.
Same thing with paracetamol. There is no need for injectable. You can use tablet. Isn't it?
But absorptions bioavailability will be different. But nifedipine we have oral better thing, so we have gone for oral, madam.
Okay.
One thing, was she taking orally? Like she was having a GCS of 13. Was she able to swallow properly?
Yes, ma'am.
Okay.
Yes, the airway was patent and she was able to swallow properly.
Swallow. Okay,
Yes.
fine. So next.
No further seizure episodes. BP recordings was below 140/90. Urine output 50 to 60 ml per hour. Deep tendon reflex 2+, and respiratory rate of 16, and saturation of 98% on 2 liters of oxygen. And serum magnesium after 12 hours is 5.3 milliequivalents per liter. And after 24 hours, it becomes 5.8 milliequivalents per liter. And GCS become 15/15 and no bleeding PVR. And no fever also.
You mentioned about the drugs. Go to the previous slide. Yeah. Anything else? Did you give her, or would you like to give her if you?
If we are suspecting the prolonged stay, maybe we may have to add bromocriptine also, madam, for lactation. So mother may mastitis prevention and all.
What about antibiotics? Did you give her any antibiotics? Or you were happy with 16,400?
Though we
Okay,
suspect,
yes.
we have missed here, but though we suspected it is.
Yeah, that's what actually I wanted to ask. Yeah.
Thank you, madam. We missed to right here. So we have started on basic antibiotic, madam. So that there could be some aspiration, which that could be even simple chemical or some bacterial, we don't know. So safer side, we have, though we have started on injection ceftriaxone, madam. Ceftriaxone 1 gram IV twice daily, madam. We have kept her on injection ceftriaxone.
So what would if at all there is, suppose there's an infection, what are the more likely sources of infection in this case? She coming from a peripheral center, reached you in the first 24 hours. I mean, she has just reached you setup. So what are the possible sources of infection?
Puerperial sepsis, so delivery site, so the skin contamination, that could be first should be seen, madam. So my first priority would be that surgical site, how there is any
Yes.
crepitus present or tenderness, crepitus, any pus discharge or any discharge, change mucopollulant discharge.
And what are the organisms would you like to cover?
So we would like to cover because the skin commensals, so Staphylococcus aureus and anaerobe coverage also would be required.
Yeah, anaerobe coverage also should be there. So if subtraction is adequate for anaerobes?
Ceftriaxone as the third generation cephalosporin, it has lesser coverage of anaerobes, madam. Maybe
Yes.
metronidazole also need to be.
Yeah, for a patient of that degree of sickness with complication TNC, it's probably 16,400 is a bit high to ignore.
Okay.
You should give the antibiotic, and once she is improving in the 48 hours, de-escalate and stop. But
Yes, ma'am.
antibiotic has to be given in that period of time. Right.
Okay.
What about you showed one of the investigations with D-dimer was high. Why
Yes,
was
ma'am.
it done, and what is its significance?
So,
D-dimer is for is checking any pulmonary embolism, like any DVT or something is there to
Okay.
rule out that
But
we have.
so what
but
was your final diagnosis? It was eclampsia, right? So what would be the why this D-dimer is so high?
Usually it will elevated in pregnancy also, madam.
post-delivery
Is
state,
pregnancy elevated to this extent? What is the
post-delivery status. So post
it was in
surgical
which
post.
unit? It's in
Hmm?
2000s, no? You mentioned about 2000
Yes, ma'am.
something. Oh,
2000, 2300 something. Madam.
yeah, it's quite high, isn't it? What is the upper limit in your lab?
So so more than 500 is our thing, madam. So it is quite high, madam.
It is
2317,
quite high.
but it should
What could be
be
the reason? Just post-op, you believe, or anything else?
post-operative period and we are thinking more related to post-operative period only, madam, and for the time being. So we're not thinking any other thing. Could be post-operative.
So also this patient has eclampsia going. That's a severe form, isn't it? From the
Yes,
severe
ma'am.
eclampsia with preeclampsia severe features going on to develop eclampsia. So it is also known to be associated with DIC
Yes, ma'am.
of various degrees. We have not done the other components of the coagulation cascade. It's not necessary also, but this is very much could be due to that mild DIC which is underneath. She's lucky that she has delivered and there is no PV bleed as you're saying, but it is a indicator already that she has severe feature which includes this DIC as well. So do you like to treat this, or would you like to repeat and see the progression or the reduction on the number subsequently?
It's better to be repeated, madam, rather than treated at its present, madam. So D-dimer has,
Why to follow?
if at all, if it is not a post-surgical state, if it is really any DIC component is developing, there would be further rise of the D-dimers, madam.
See, doing D-dimer, whether it helped you in managing the patient?
So it won't be changing in this present scenario of the patient. It won't be changing for the course of the management, madam. So if needed only, we will be repeating the D-dimer. Otherwise,
Yes, because
Yeah, there is no indication to do D-dimer
yes, ma'am.
because anyway it will be elevated.
Yes, ma'am.
The rate of elevation or the actual value of the test doesn't tell you anything.
Yes,
Okay. So clinically, you have to decide whether patient has any signs of DIC or
yes, ma'am.
based on it's predominantly clinical decision.
Yes, ma'am.
D-dimer doesn't tell you anything.
Yes.
and D-dimer, what is the cost of the test? It is around 2,500 to 4,000. Remember,
Yes, ma'am.
something that I probably remember. It's an expensive test, so it's probably that is but not necessary. Chest X-ray shows light load zone infiltrates, and that would probably will be good enough with a post-op status, post-ictal state to explain the hypoxia. So pulmonary embolism, either from the venous or amniotic fluid, is absolutely excluded. Is on very low on the list for this kind of patients, but not necessary. I'd just be interested to know what anesthesia was given to her for delivery of the child in the previous place where she was operated.
Spinal only given, madam, since platelets, everything within the normal limit, they did under spinal only, madam.
Spinal anesthesia. So tell me in nutshell, what are the challenges in giving spinal anesthesia for a lady who's had been high blood pressure, for a lady with severe preeclampsia?
So, as there is in a gravid uterus, atriocaval compression, there would be epidural vessels engorgement will be there, madam. So, and also because there is already hypertension, that also can increase the bleeding risk will be there, madam, and there would be some formation of some hematomas risk would be there, madam.
Yeah, that one thing. And what else? What else? Anything else?
And high spinal.
So what about like if you have to judge versus or weigh spinal versus general anesthesia?
Yes, ma'am.
What would you choose?
So if general anesthesia chosen, that will impact the fetus also, madam. So better to go for neuroaxial anesthesia if there is no other reason to avoid it. So better to go for neuroaxial anesthesia only, madam. So in order to save the fetus from the compromise.
Now, why general anesthesia will be detrimental to the fetus?
There is the difficult airway is like more than 10 in 8% have this difficult airway in pregnant woman. So bleeding complication of and all are less with spinal comparatively.
So if, having said that, so if there are indications for general anesthesia, patient is very nervous, patient's airway is compromised, you cannot give neuroaxial blocks. You have to give general anesthesia. So under those, you have to keep in mind all the possibility, all the complications that can happen. I think Dr. Amarja has already asked you what are the complications. All this can happen in a patient who is on the going to the OT table. So you have to have your airway. Always a difficult airway trolley is definitely must recommend for such cases. To call for help, have at least two hands who can be, helping each other. Two good IV lines and anti-epileptic drugs should be there because patient might just seize on the table also, right? You used to, because the definitive therapy is termination of pregnancy whatsoever. And after that, whatever happens can be taken care of. But once the baby is out, the cause is out. So that is the most definitive, it has to be done. But in case of when you're giving spinuraxial block, it is preferred. Now the platelet is better. I mean, it's more than 1 lakh. But also it has to be seen that there is no precipitous drop in blood pressure because once you give the neuroaxial block, there is vasodilatation. So BP should not fall suddenly. That has to be avoided. So either graded it is good to give, if time permits, to give graded epidural or give agents. The mixture can be decided that there is slow fall in blood pressure, not rapid. And IV fluid, etc. These should be there. And also immediately postpartum also they might go into pulmonary edema, this like might seize, they'll have bleeding. Chances of peripartum hemorrhage are actually high in this kind of cases. And not all places can have, all this coagulation test done before delivery. It's not possible. So all this preparation should be there in anticipation before the child is delivered for such kind of patients. And this is definitely be asked if there is a case how you give anesthesia for this kind of patient. It will be definitely asked, right? And if we have to intubate, suppose the patient we are giving preparing to give spinal anesthesia and the patient now has a seizure. So now you're not able to complete your neuro anesthesia blockade. You have to intubate and go for immediate delivery of the baby. What agents will you use to intubate these patients for rapid intubation and delivery? How will you intubate?
Succinyl choline.
We will use succinyl choline, fentanyl, and some midazolam also we can use that, madam, or for induction.
Rapid sequence.
Rapid sequence induction we have to do, madam. We have to pre-oxygenate with 5 minutes.
At least for 5 minutes, because the functional reserve capacity would be less for the pregnant mother. So we have to be pre-oxygenate for 5 minutes, and then we will use general either succinyl choline or succinyl choline or fentanyl with some added midazolam, so that induction would be proper. And we will add some scheduled relaxant like rocuronium to facilitate the intubation and also better control, so that less irritation over the during intubation, and there is a less bleeding chance also, because more forceful thing can lead to, because already friable capillaries, so they will be bleeding, and it will further block the tube in the due course of the period. So we should take care of all the things.
Small tube also we have to use,
and we have to use smaller tube.
Yes, smaller tubes. And also you can use agents like Dr. Sriram, somebody is writing here also about, you can use propofol also. It's a good agent around that period for intubation, facilitating intubation, but it has to be slow and graded so that there is no rapid fall in blood pressure. So once you have tubed, the baby is out. It's a matter of less than a couple of minutes for the obstetrician. They'll be ready. But you have to have both the options very much ready at the bedside for the best of the patient's outcome. I think one of the questions in the chat box was asking about somebody asked about if antibiotics are necessary if the wound is healthy and there is no fever with a TLC of 16,000. So what would you answer that? How do you answer?
Yes, madam. As we have already thought of the same thing discussed earlier, so it could be more of reactive. But the thing is, given in the setting, so ideally that could be if in that scenario, sending some early blood cultures and then using the antibiotic would be beneficial rather than going for a strict antimicrobial stewardship and not using any antibiotic and later on landing the patient into puerperal sepsis and adding to mortality. So I would be in this scenario. I would like to tweak certain rules of stewardship and we'll go for antibiotic for the better outcomes.
Yes, with that kind of situation with the 16,400 and a patient who has already had complications, it would be definitely recommended to give antibiotics, send the culture, screen for active sepsis, and de-escalate and stop antibiotics rather than continuing it for 5 days, 7 days, giving oral antibiotics at discharge, which is not necessary. But not giving antibiotics is definitely not a prudent decision at this point. So we answer is yes, we'd give antibiotics for those cases, right?
One more thing I would like to add. See, we cannot just tell that based on the count that there is infection. We
Yes,
have to
ma'am.
find out what could be the source of infection, like surgical site. And here the stage 6 is showing right lower zone infiltrate. So probably there is a possibility of early pneumonia. And based on that, you are going to choose your antibiotic. What could be the site of infection and what antibiotic is safe. Okay, so third generation cephalosporin could be adequate if you are thinking right lower zone infiltrate is a possible site of infection. And maybe you can add a typical cover in this situation. And which agent you would like to use for a typical cover in pregnancy?
Azithromycin should be the choice,
Yeah,
madam.
so doxycycline is contraindicated. So drug of choice is azithromycin. for
Azithromycin.
typical cover. Yeah.
Any other
There's a
question?
question in the chat box about role of dexmedetomidine to suppress the intubation stress response. What would be your answer to that?
Alpha Dex. And Alpha Dex is a relatively safer option. It can also control to some extent blood pressure also, madam. But our experience with that is less, madam. So I think we cannot answer it in a justifiable way, madam.
Yeah, so dexmed actually has not been not much literature info you find in pregnant to be used in pregnant ladies for this and this patient who is probably is having seizure and there is fluctuation in the hemodynamics. I would refrain from advising anyone to use dexmed in such cases. It is a good agent, but different indications would be there. All right. So what happens to you? I think we are coming to the end of the case. You can go to the last slide if you have any. Yeah.
Day 3 GCS of 15, of pulse rate of 110 per minutes and BP of 130/80, no headache, no further seizure episodes. CBP of hemoglobin of 13.1 and total count of 11,600 and platelet of 1.55 lakhs and sodium of 135 and potassium of 3.9 and chloride of 101. Shifted to ward in stable condition.
Right. So, what was your final summary diagnosis after 3 days?
So she's a 31-year-old female, primary gravida with post LSCS status, eclampsia. So being managed with the magnesium sulfate infusion coupled with lavatory system and with minimal O2 support in view of aspiration, some antibiotic was added and slowly patient has recovered in a by sticking to the protocol, patient has recovered very well and we could able to salvage the patient with lesser complications.
So, with this image supported diagnosis of also PRES, posterior reversible encephalopathy. Also, so what is the prognosis of PRES?
So over a period of time, once the blood pressure comes under control, it can be reversed, madam. So nothing as of now, it is not too worry scenario, madam.
Right. And how
But
long to be lever to be continued?
madam,
Levetiracetam. She was given levetiracetam on the advice of the neurologist, as you mentioned.
yes, ma'am.
Does it need to be continued? And if yes, for how long?
So as we have thought that eclamptic seizures could be still 6 weeks of postpartum. So we may require it till that period, madam, as per the neurologist advice.
Yes, at least 6 weeks should be given. And then
Yes,
in the follow-up OPD, you screen these patients.
Yes.
So answer to, I think there is a couple of questions on Levera in the chat box. So answer is yes. It's not only for breast because she also had seizures. I would be also inclined to add this anti-hypertensive, anti-epileptic agent for that matter. And there is one more question, magnesium sulfate to be continued for how much long after the delivery?
Up to 24 hours, madam. Up to 24 hours or after the last seizure episode. So if the seizures are continuing, we may have to continue. Otherwise, up to 24 hours of the postpartum.
Correct. What are the parameters of hemolysis to be checked for? How do you manage?
So the hemolysis parameters which we see is, one is because of the microangiopathic hemolytic anemia, we will see the schistocytes in the peripheral smear. Lactate dehydrogenase levels would be higher, more than 600 in the Mississippi classification of triple classification also, and also we will be looking at the haptoglobin levels which were very low. And
how do
there
you
will be
manage?
indirect bilirubin rise more than 1.2.
Right. So LFT will be also accordingly
Rise.
reflect that. So how do you manage that?
So once the thing is, once the patient recovers, so it could come back to its normal over a period of time.
Yeah. So even if it is, suppose it is present, suppose you had sent a peripheral smear. So
Yes.
always these kind of patients, it's better to send a hemogram, which also includes the peripheral smear. Even if it is present, your D-dimer was so high, but platelet was 1.3 lakhs. So you need not, because the patient is not actively bleeding, there is no signs of anything else you see. The LFT is not rising. Patient actually clinically getting over well. So
Yes.
there is no need to treat the reports. We treat the patient, not the reports. That is one dictum we always follow. And it only adds more information to what you are dealing with. But otherwise, we did not treat these reports because this patient, and this is one of the fully reversible etiologies. Once the baby is delivered, and thankfully she was also past 32 weeks, all organ dysfunctions, if they are not advanced, tend to recover. So
Yes.
most of the obstetric etiologies, if you see, if we are intervening in the right time, they have excellent recovery.
Yes.
And I think, having covered this obstetric patients over decades now, what we feel is patients, our maternal mortality rate in the country could be further brought down if you just address these patients at the right time and refer them to the nearest referral center in the correct time. Now, thanks to technology that we have this provision of telemedicine and tele-ICU, at least, we can give informations and guide them how to at least stabilize this patient. And safe transport of this obstetric ill patient is also of paramount importance, which will be definitely have a impact on reducing their morbidity and mortality further in future.
Yes.
Because many times we see that patient would have given shots of boluses of magnesium sulfate and patient would have come and just died. When you dig the history, you find they had received magnesium sulfate. Simply oxygen has not been given, no IV cannula during transports. So these are small little things actually you can do towards reducing the morbidity and mortality. And preeclampsia and peripartum hemorrhage, they remain the two most common predominant causes of maternal mortality worldwide, not only in India, worldwide. In fact, in the Western developed countries, you see with the increase in the maternal age, lifestyle changes, all these addictions, etc., coming now, and this anti-fertility treatment also, incidences of preeclampsia is rising very
Yes.
much. And essential hypertension also is setting in the younger age. So these complications are going to be there. So good ANC screening, early referral, and the multidisciplinary team management remain the key. Thank you, Dr. Sachin and Dr. Jivan. It was a good case to discuss. And thanks to Dr. Venkat and Dr. Kaladhar, Dr. Amarja.
Madam,
They
one question. Can I ask
Yeah.
one small doubt, madam?
Yeah.
So regarding this preeclampsia screening tools, I have just read one thing, madam. So whether that can be implemented at the earliest level in India. So are we having any using the tools, madam? Preeclampsia screening tools out of the Pelican study, that serum plasma growth factor values and all. Is there any?
No, plasma growth factors we are not using as a screening. See, what are the criteria of a screening test? It has to be, available, doable. There'll be good, clear-cut cutoff marks and cost. These are at least 4 or 5 features of a good screening test, which is doable. So all this, there are many researches going on this, early kind of cellular or the this serum level indicator biomarkers, but nothing has been validated in the context of pregnancy for screening, especially for preeclampsia. So as of now, globally, and which is being highly recommended, is to look for proteinuria. And it is not only the blood pressure numbers. If a lady has beyond 24 weeks, 20 weeks, proteinuria is double plus and more than that, definitely this patient has a tendency or higher risk of developing preeclampsia with a reading of, as I said, up 130, 80 or 125, 85 doesn't matter, but it comes in the category of preeclampsia. And the latest, all the society guidelines recommend that, and obstetricians very much emphasize on that. And this dipstick is very cheap. I think most of the district hospitals, even in our state, I'm sure in most of the states in India, they use it because the dhais, the paramedics, they just do it for the lady once they come for the ANC. So that's a very good screening test. And early confinement and early referral is, I think, best bet to save these patients for the mother and the fetus. Yeah.
Thank you.
Yeah, thank you, ma'am. So, couple of questions, ma'am. Yeah, question to Marja, ma'am. So, generally, what happens to these patients, those with preeclampsia and eclampsia, landing up with HELLP, presenting with neurological abnormalities? There is a platelet count drop, thrombocytopenia, probably sometimes a setting. And these patients, most of the times, overlap with thrombocytopenic purpura. Even patients can, because of hemolysis, they may be having cystocytes also. We had seen a couple of patients like that, and it is a bit difficult decision at that point of time whether to go for any plasma exchange or not to, because if it is TTP, if you are not doing plasma exchange in time, definitely it's going to be having a bad mortality. So how do you differentiate generally? How do you decide in those type of scenarios?
So basically, the low platelet count, there are various differentials, and we need to identify, is it because of reduced production of platelets? Is it because of increased destruction, or is there sequestration of platelets? And if post-delivery, we have to see how is the progress. We have to look at the trend. The single value of platelet or other coagulation parameter is not going to tell you what is the diagnosis. So for HELLP, it can be partial HELLP syndrome, like only elevation of liver enzymes or low platelet count. All the three features may not be there. However, once delivery is post-delivery, you will see there is a gradual improvement in the coagulation profile. That is the first thing. With respect to TTP, there are total 5 features, but again, the chances of having all the 5 features is rare. So best thing is look at the peripheral smear. So peripheral smear can tell you how is the cystocytes. So if you are seeing more cystocyte, look at the LDH. LDH is very high and patient is having persistent seizures. So only way to confirm your diagnosis, the clinically, if you are not seeing all the 5 signs of TTP, you have to do ADAMTS 13 level. That can help you in confirming your diagnosis. Having said that, the availability of the test is again a problem, and timely getting the results is also difficult. So in this situation, what you can do is, if patient is persistently having coagulopathy, rising LDH, so LDH in HELLP, it could be around 400, 500, but in TTP, it could be rising around 1000, 1500, and persistent seizures, there is no control, and rising cystocytes. So peripheral smear is easily available test. If you see the peripheral smear, suppose yesterday you have done and today you are repeating, and there is a rise in cystocytes, features are fitting into possibility of TTP. And when you have strong suspicion that TTP is suspected, better to start with the plasma exchange rather than waiting for ADAMTS levels and see the response, how patient is responding. For HELLP syndrome per se, there is no definitive treatment. After delivery, you are going to see the recovery with HELLP patient. It's not like for HELLP syndrome, there is a particular drug you are going to use. As against TTP needs specific treatment like in the form of plasma exchange. So my advice would be do the peripheral smear, which is easily available. look at the cystocyte count and see the trend of LDH. And if you're strongly suspecting, there is no harm in starting plasma exchange, because timely intervention is going to improve patient's outcome.
Yeah.
Along with HELLP, TTP, there could be some autoimmune disorders, which are very common in this age group. Okay, so as I told you, plasma exchange, if you are strongly suspecting, there is no harm in going ahead. And once you get the reports, you are just confirming your diagnosis. So that could be my answer.
Yeah. Probably, I think you are in too much in dilemma with overlapping features. I think favor plasma exchange, do 1 or 2 exchanges, and meanwhile, probably if you
Yes.
get Adams 13 and all, you can look at it and just stop it there, because generally it can be performed safely in ICUs and all.
Yes.
The another overlapping, ma'am, the question to Dr. Sharmili, ma'am. So these patients like HELLP, again, the same thing, they can be landing up in liver failure. Most of the times, again, there will be overlapping AFLP, worsening liver function. We did see some patients who progressed, started with preeclampsia, severe preeclampsia, delivered HELLP, and then their liver failure progressed very badly to the extent of 2022 bilirubin and all. So this is also a bit AFLP also sometimes the same thing, like do plasma exchange or not. So in these scenarios, how do you deal with these patients?
Yeah, AFLP, as you said, see, if it is all the problems are solely due to preeclampsia or eclampsia, that is the definitive termination of pregnancy is the answer. But after the termination, also, if all these features are, suppose the predominant hepatic dysfunction, as you mentioned, if it is happening, then it is more indicative towards the AFLP, acute fatty liver of pregnancy. It's a rapidly progressive and a fatal condition. And in that case, if you rapid rise in bilirubin and all other related functions like coagulation, bleeding, everything starts worsening. So if it is proceeding in that direction, so you have to have plasma apheresis with this filters, etc. I think it is again better to start early rather than waiting and trying to do it. If the family is convinced with the cost and other aspects, better to go for it early. And if you bridge that therapy, the incidence, if you look at the literature, the incidences or the cases of successful liver transplant in pregnant patients, it is very, very less. And in a case series of around 10,000 cases, only 4 cases were there where postpartum ladies had received liver transplant. Because most of the studies of the literature, whatever has been done, have excluded these pregnant patients. So literature-wise, we do not have much data on this. But yes, clinically, as you say, as you discussed the first case, rapidly for worsening neurological status with more of cystocytes, hemolysis, more in favor of TTP, go for it. Similarly, for this case also, if everything else is excluded, more in favor of AFLP, and if it is giving time, then it is better to go for this plasmapheresis with this bilirubin filters and the other supportive therapies than not.
Yes, ma'am. Thank you. Actually, one case I want to share right now in our unit, around 32-year-old conceived through IVF, having been gestation 20 weeks, presented with severe community acquired pneumonia, ruled out the swine flu and all, requiring HFNC and NIV support since 1 week she's there. So the initial, there was a transaminitis. Now we were monitoring the CE. Initially it is 1+, now it is 2+, 3+, and then the transaminitis is worsening. So there is not much of thrombocytopenia actually. So we are actually at the stage of terminating a pregnancy because our obstetrician told she's fitting in criteria of probably partial HELLP. So we do see sometimes complete HELLP, partial HELLP this time. And even the pneumonia is a concern in this patient with hypoxia. So this is also a bit difficult decision because she conceived after almost 8-10 years with a lot of treatments undergone, with twin gestation, lot of trauma to the patient. Very difficult to convince them. I think this type of scenarios are also a bit difficult, ma'am. Yeah.
Yeah, I think, I mean, all pregnant ladies are also prone to all other common medical diseases that we already know of. So they can have pneumonia, they can have urinary tract infections, they can have a perforated peptic ulcer. So all this can happen. But then when it comes to the situation, as you say, your obstetrician rightly advised, the termination of, even for AFLP, the absolute answer is termination of pregnancy. Because the mother has to survive for anything else. If the mother dies, the fetus will certainly die. At 20 weeks, the lowest we know is, I think, 24 weeks fetus have survived in India. And somewhere I heard about 20 weeks also. But if it is coming to that kind of alarming level of organ dysfunction, which is rapidly progressive, we have to get rid of you have to terminate the pregnancy. that is there. And many cases it is, we cannot have the clear-cut diagnosis of this versus that. It will be overlapped in patients who have got multiple organ dysfunction. There will be overlap. But all we do as the dictum of principles of management remain in critical care, it is supportive. While you look
Yeah.
for the cause and try to do what are some definitive and the supportive, then things take its own course. Yeah.
Yeah.
Thank you.
Thank you very much, ma'am. It was a very nice discussion. Thank you very much, Dr. Sharmili Sinha ma'am and Dr. Amaja ma'am, for coming on board and being expert panelists. Had a very good discussion. Thank you, Dr. Sachin and Dr. Jeevan, for bringing out that case, which led to very good discussion. Thank you, ma'am. Thank you very much. Thank you all the delegates who attended online. I think more than 80 people attended. And thank you our branding team and Yashoda Hospitals for giving this platform regularly to interact
Thank
with
you.
experts.
Thank you, Kaladhar, and all the discussion. It was wonderful learning experience. And I think the scenarios which we were discussing, like we always thought about whether it is HELLP or TTP or HUS. That was always our debate over times, and textbooks always mentioned about it. We draw drawings, we draw tables, we try to teach our students that. Over a time, we are getting wiser and wiser. We are saying pregnancy can trigger TTP, pregnancy can trigger HUS. You may have initially thought during antepartum period or during pre-delivery, it is a HELLP. You deliver in next 48 hours, 72 hours, your symptoms persist. Your TTP on card is high, your cystocytes are going up. Don't wait, go for a plex. There can always be an overlap, as Dr. Sarmili pointed out. So we are talking about the overlaps are not uncommon, and it is no more just a discussion. It is on textbooks, it is in literature, it is everywhere. There are classified tables differentiating postpartum, patients worsening, cystocytes rising, organ failures worsening. Don't wait, send a Adams stage 13, but go for a plex if you are in doubt. I think that's where we are actually moving forward. But wonderful discussion. Thank you, Kaladhar. Thank you, Sarmili ma'am and Amarjama for the discussion, and Sachin and Jeevan for bringing that. I think
Thank you, sir. Good night.
Thanks, Dr. Venkat, Dr. Kaladhar once again, and Team Yashoda, and Dr. Sachin and Dr. Jeevan. All the best.
Thank you.
See
Thank
you
you all the
sometime. Thank you.
participants.
Thank you, ma'am. Thank you, sir.
Thank you.
Thank you.